Hi, I'm Tisha Monteith. Welcome to the American Headache Society Leadership Development Series. I'm delighted to talk with Jason Sico, a very good friend of mine, about all the wonderful work he's been doing at the VA. Why don't you introduce yourself?
Absolutely. Tisha, thank you very much. I appreciate it. And so as mentioned, my name is Jason Sico. Like all of us, wear multiple hats. So I serve as the VA's National Director of the Headache Center of Excellence, or H2E for short. And we'll talk a lot more about what the H2E is, its history, what we've been able to accomplish both for veterans as well as for headache medicine at large. I also serve as an associate professor at Yale University School of Medicine in the departments of neurology and internal medicine. My clinical training is both in neurology and primary care medicine, and I've always been drawn to headache. As we both know, headache affects millions of people. We know also that headache affects more than 2 million veterans actively getting their care in the VA. I myself come from a family of veterans. So both my grandpas, and I'll talk a little bit more specifically about my grandpa Sico. He was an Army veteran, he was in the Army. Didn't talk about his time in Korea all that much. The only thing that he did share was that he was blown off a mountain, and every day after he regained consciousness, he had headache. And I would see how it affected him. When we would go to visit him, my dad would take us down, and we lived in Scranton, Pennsylvania, so it took maybe 5 minutes to get to his house. And as I got older, I would take him to his appointments at the local VA and would repeatedly hear time and time again, "We don't have any good treatments for you." And it broke my heart, but it also broke his. And through some of those experiences, I've also got to learn that veterans are an amazing, resilient, wonderful group of people. They've done tremendous service for us, for our country, and for our way of life. And they're some of the most deserving, wonderful people that you'll ever want to meet. And part of why I do what I do is similar to you when we're in clinic. There's that one person sitting in front of us, that one person that's coming to us for help. And how could we help that one person? Recognizing that they are a person. They have a life. They have personal goals. They have professional goals. They have family, friends. They have a life outside that clinic room. So how could we improve that end of one person's life by improving their migraine and headache care? And I come to that clinic room thinking, well, how could I help someone's grandpa? How could I help someone's aunt? And I think that keeps us going when we recognize that some days at work are easier than others, but really being able to keep that one person front and center. And I know we're going to talk about how do we deliver the highest quality care using information, data from our electronic health records to make sure that we're doing the best thing for our patients. Also recognizing that, thankfully, the headache and migraine therapeutic landscape has changed tremendously since we first met and continues to make great and wonderful strides. So how do we incorporate new therapeutics into sort of what we do and how we deliver safe, equitable, efficient healthcare?
Yeah, so many people have been advocating for headache care, better headache care in the veteran population, and we're so lucky that we have you as an insider in the system who's now taking on such an incredible leadership role. And as we focus on leadership, I want to ask, first of all, we should first talk about what headache excellence is, because we don't really have a formal definition for what that is. What are some of your thoughts in the VA health system as you've submitted some of these proposals?
Yep, absolutely. And you're quite right, where we know that delivering the highest quality headache care is important. We also know that to advance headache as a field, we need more than just clinical care. Education is a really important, huge part of it, because let's face it, for as many people as there are in this world and in this country that live with migraine and other types of headache disease, only a very small number of those ends of one will come to see us for their headache care. So how do we educate, empower other healthcare providers to do the best thing that's guideline concordant, but also being able to develop treatment plan that resonates with someone's values and preferences? how do we teach many to do that? How do we teach learners that are with us to get them inspired to do headache medicine? So education is a big part of excellence. Research is hugely important. We wouldn't have so many of the treatments that we have if it wasn't for research. But also recognizing that research comes in different types. There's clinical epidemiology that helps us understand the burden of medical and mental health comorbidities among those living with migraine and other types of headache disease. We absolutely well aware of clinical trials, translational research. I think across those pillars of clinical care education and research, being innovative. So how can we do things that are cutting edge in such a way that we are able to introduce the best practices, but also continue to do several things. One, drive the field forward, but also be reflective. How can we get information, data from individual patients and then other work units? So a work unit could be a clinic, it could be a whole series of clinics, it could be an entire center, an entire healthcare system. So how can we seamlessly get information from all those ends of one to help us understand how we do better? So in the VA loves its directives. So there's one called Directive 1215 that defines what a center of excellence is within the VA. Not specific to headache. There's several neurology centers of excellence. There's a geriatrics one. There's a military exposures one. But in that, it talks about things regarding having excellence in clinical care, education, research, being innovative, but also adopting a mentality of a learning healthcare system. So again, how do we use the information that we get in routine clinical encounters to understand the current state, what type of care we're delivering there and in a short period of time, but how could we continuously improve what we do? Folks could decide to be stagnant in the type of healthcare that they deliver, or they could open their eyes and say, listen, these are opportunities for us to understand how we're doing for our individual patients, for a panel of patients, but do so in such a way that we want to make sure that we continuously do the best that we can. So in that directive, it helps to give some guidance in terms of what it means to be excellent, but also recognizing that excellence is an interconnected concept. And it's not relying on one metric. So we both know, we've had previous conversations about the large number of people with migraine and headache disease that sometimes, and even oftentimes, get suboptimal care. So how can we improve the care quality, the care delivery, and the access to care so that people could get the best care possible? And there's no easy answer. So excellence, I also believe, is being able to come up with care delivery models that sort of meet the person where they're at, but also recognizing that there are some truths to resource limitations. We well know, and the headache community knows, that there's not enough headache neurologists. We also know that there's just not enough people that have the expertise to appropriately take care of headache. And that also means evaluating them, managing them. And we both know that starting off and getting the best and right diagnosis or diagnoses, that's the most important part to understand what types of treatments we could and should be offering. And we've both, and others listening, have seen patients that have carried a diagnosis for a very long time. And you actually sit down and talk with them, lean into our training and ask them other types of questions, and find out that they've been misdiagnosed for a very long time. So, but also recognizing again that there's millions of people out there. So being able to get a sense of what types of people living with headache are best managed in primary care, getting a sense of, are there ones that have not responded to other treatments or have more complex health care needs? They could be from medical problems, mental health conditions, but then also who may need an entire team to take care of them. Recognizing that, again, we have so many tools in our armamentarium to treat people, and they're not just medications. Some of them are behavioral intervention. Some of them are rehabilitation interventions. So there's good evidence for exercise as a migraine preventive. So trying to get a sense of who best should be managed in primary care, and then getting a sense of how can we sort of educate and empower primary care providers to make the best diagnosis, offer treatments that they're comfortable with. Some treatments that are commonly used in primary care are also ones that they could and should be very comfortable with when it comes to migraine prevention. But also getting a sense of when is the right time to send someone to a neurologist. So let's face it, in a perfect ideal world, there's resources galore outside the VA, inside the VA. So anyone with migraine or headache disease could see a headache neurologist and then coordinate care, but we don't live in that reality. So how can we do the best that we can, empowering people with education, empowering them with the skills that they need to make the best diagnosis, craft the best treatment plan, but one that does not leave the person or the veteran living with headache disease out of that equation, out of that conversation. So I believe excellence also has to do with listening to the individual veteran, but being able to come up with healthcare delivery models that meet the needs of given people living with headache at a certain time.
So why don't we talk a little bit about strategic initiatives for building those centers of excellence and ideal or improved health systems for our patients, as you mentioned, for more equitable care for this highly disabled population. So what are some key tips for building really robust clinical strategic initiatives?
Yep, absolutely. So the Headache Centers of Excellence came about in 2018, so we're still a relatively newer program. But very early on, I set forth on the mission that with the 7 centers that we had, we need to understand, well, what kind of expertise do we have currently, but also what does it mean to be a center of excellence, going back to what we were talking about before. So we interviewed dozens of people outside the VA in the broader headache community that have established really wonderful, fantastic centers that have helped hundreds of thousands of people. And we asked the question that you just asked. Who should be on the team? What are the services that are appropriate and necessary to deliver excellent care? Help us understand patient flow. Help us understand what types of patients are best serviced within your centers versus which patients that get referred to you were like, geez, I wish I saw this person 10 years earlier.
Yeah.
So again, being able to get the right care to the right person at the right time. So we did a lot of listening. And one of my bosses loved the phrase that we were also building the airplane while flying it at the same time.
Okay.
So meaning you could either stay in the hangar and build the airplane until it's absolutely perfect and wait 10 years for that to happen. Or say, listen, we're going to do continuous quality improvement. We have the first airplane, and then we're going to continue to build it and get better as we learn from within the VA and then outside the VA. So some of the things that we've developed early on had been staffing models. So what are some of the things that headache neurologists and neurologists should be doing? Also recognizing that someone does not have to be a neurologist to get UCNS medicine certified. So we have physiatrists and internists that have gotten UCNS medicine certified. But then what other members of the team are really important? As we both know, there's been an explosion of pharmacotherapies, both for prevention as well as treatment. I love working with clinical pharmacists. I think when most of us think about clinical pharmacists, we're thinking about someone at Walgreens and they're giving us our prescription. The amount of training that these folks get are amazing in terms of medication adherence, understanding effectiveness, side effects. It's completely within their scope of practice to prescribe medications, titrate things. In fact, one of the few things that's not in their scope of practice is making a new diagnosis. So one of the sort of care trajectories or care plan that we have is we see people that have been fairly refractory to other types of treatment, and then they see myself or another headache person. They'll see a pharmacist, a health psychologist to talk about behavioral intervention, as well as targets that would be amenable to behavior change. Nursing, and we also have our nurses get trained in what's called whole health. In the VA called whole health, I think more broadly known as integrative health or complementary and integrative health. So being able to have that toolbox at our disposal for an individual person. Also, we have physical therapists on our team, talking about exercise, doing a full neck exam, looking for TMJ, and things that I will tell you, like I sometimes didn't look for. But we have a team, again, looking at the same person in different ways. And oftentimes we're finding that someone deserves a multimodal approach. And we've both seen patients that we've talked to say, listen, we think you would do great on this preventive and this abortive. And they're like, that's fantastic, but I don't want to take any medication.
Yeah.
So how do we meet someone where they're at? So once we have that team and we've made the best diagnoses, and then we've talked about different combination of providers, seeing them after the fact. So I'll focus on our friend, the clinical pharmacist. So we decided to start a non-oral standard of care preventive. The pharmacist is seeing them within 2 weeks, monitoring their blood pressure if need be, doing teaching in terms of auto-injectors. And then the pharmacist is seeing them every 2 weeks or every month. And that could be in person or that could be telehealth. So each and every one of those subsequent visits, that's a visit that now is open for me to see someone to make sure that they have the right diagnosis and then being able to craft that treatment plan. So that's just one example of us being able to take a team-based approach, leveraging individual providers' time, talent, and expertise to extend the reach of what we do for headache. Again, recognizing that a physician doesn't have to do it all to deliver the best care possible, because we know that there's so many people that need to see us.
Great. So I think that really goes into seeing things differently, having an innovative approach, and really team building as part of key components of your strategic initiatives.
Absolutely.
I do want to talk about EMR, electronic medical records. I think the VA is notorious. When I was a resident, I loved it. I think it was well ahead of the game. How do we utilize or EMR to improve care? We talk about healthcare equity and a number of measures in terms of preventive therapies and making sure that our patients are on the most appropriate treatments. So how can we use EMR to leverage this as well as capture ideal metrics?
Yep, absolutely, and thank you, because I am such an EMR dork and I love data, so I get very passionate about this, but also get passionate about putting data and high quality data into action. So I think foundationally you need to get a sense of, all right, well, does your EMR capture the data that you need? And oftentimes that becomes a combination of structured data, things like ICD codes, CPT codes, prescriptions, and then unstructured data. So meaning what's written in a clinic note in like free text.
Yeah.
And now that we're rapidly progressing through the era of AI, the combination of structured and unstructured notes could be used together in amazing ways that we haven't even dreamed of. I think being able to use those data, and I'm going to go back a little bit to structured data, to get a sense of, okay, well, and this example will come from the VA, but is not VA EHR specific or EMR specific. So as providers, we see patients, and we put ICD codes in, we put CPT codes in, we put referrals in, we prescribe medications. In EMRs, we have unique identifiers. So then they say, okay, well, in the last 6 months, Jason, you saw X number of people, and among those, this percentage had migraine, this percentage had post-traumatic headache, this percentage had headache, and also had burn pit exposure. And among these patients, X number had triptans, Y number had GPANs, Z number had any kind of preventive. And so I think having data capture like that, that's now available in EMRs, is really useful as sort of foundational. So to say, okay, well, how many people are we seeing? And if you take a healthcare system perspective, that's one of the ways when Congress asked the VA to learn more about, about headache care, I could easily say, well, pick a state. What state do you want to know about? And we've leveraged the data that's collected in EMR to be able to get a sense of if it's a medical center, if it's a whole geographic area, if it's a state, the number of people living with different types of headache, who they're seeing, but also, are they only seeing a primary care provider? Are they going to the emergency department for their headache? And those type of data can be gotten from the EMR. And then, so that's one thing in terms of like data collection and then curation. That's great. That's foundational. But then to like use that data to say, okay, well, in this geographic area, let's see how migrant care differs between men and women. And then, or even saying, okay, well, what socioeconomic groups, what social determinants of health are really important, and getting a sense of, so let's just say we want to understand predictors of using the EDUs. So some of the things that we've learned with the VA data is, on average, 23% of people use the ED for their headache and migraine care at least once a year. And I think many of us listening will consider if one of our patients has to use the ED for the headache care, we fail them in some way.
Yeah.
And
That's huge.
yeah, and so to go back to the N of 1, using EMR data to get a sense of, well, what are the predictors of someone using the emergency room? And then being able to use that data to identify, lesions in the pathway, so to speak, and then come up with quality improvement initiatives to help with the goal of getting people staying out of the emergency room. And sometimes it may be finding that there's at-risk groups. So some of what we found so far is when people are more rurally designated areas, they're more likely to use the emergency room. And that goes back to something we were talking about before, but in terms of access to care. So when I sort of think about these types of things, I have to look at the entire country, the entire VA as a healthcare
So it
system.
sounds like you have big data and a lot of resources. Why don't you just give us 3 takeaway points from your experience with developing strategic initiatives for headache excellence for our listeners that might want to do this in their home institutions?
Yep, absolutely. So in someone's home institution, especially and I feel like EMRs are ubiquitous these days, getting a sense of, how could I, in a very straightforward, non-laborious way, get information on my patients that are actionable, so that being able to get a sense of how could I continue to improve things. So I think that's one way by which we could get the data that the EMR is already collecting for us to understand sort of where we're at. I do also think that we have to be open to change. So I know sometimes people don't like data. They don't like Big Brother, Big Sister checking them out, seeing what type of quality care there is. And I recognize that quality metrics could be tricky. Could be a tricky business. So oftentimes we talk about this concept of risk adjustment. So odds are, if someone is coming to see us, they have pretty severe disease. So the MIDAS score that they have compared to someone that's only seen in primary care may be vastly different. So I also recognize that it's important not to you can't just judge quality of care based on a single snapshot. You have to look at someone's healthcare trajectory over time.
Okay, so capturing the data, one. Let's get another point in.
Yep, absolutely. Getting a sense based on the business model that someone is practicing under, what types of healthcare providers could be involved in the provision of care, such that physicians don't have to do the entirety of headache care. So in the VA, it's fairly straightforward for us to have health psychologists as part of a headache team and clinical pharmacists. The VA has been using clinical pharmacists for chronic disease and medication management for decades, for diabetes, hypertension, hepatitis C has been a more recent utilization. So getting a sense based on the business model that your work unit, your healthcare unit operates under, to get a sense of what other types of members of a team can I bring on board.
And give us your third point.
Being very open to change, especially when in actively eliciting change or ideas for change from the people that we serve, mainly our patients. Because they're the one, this is why we do what we do. Because we want to make sure that we're doing the best for them.
Thank you. Thank you so much. I really appreciate you being here for our first American Headache Society Leadership Development Series, and I look forward to hearing more progress.
Absolutely, teacher. Thank you very much. This
Of
has been
course.
wonderful.